Hello guys, welcome back to my channel, and in this video we are going to talk about the obs and gynae. So here is the list of the things which we are going to talk about in this video. So it will be C-section, Preeclampsia and Eclampsia, placental abruption, placenta previa, molar pregnancy, miscarriages, uterine bleeding, adenomyositis, cervical pregnancy, uterine rupture, weakness of the labor activity, abortions, ovarian apoplexy, placenta and uterus, and in the end peritonitis. So I hope the video will be shorter, but let's see, let's have a look over it, how long it will be. So let's start with the cesarean section. Cesarean section is a surgical procedure that is used to deliver a baby through the incision made in the mother's abdomen and the uterus. So the C-section is usually performed when the vaginal delivery would put the baby or mother at the risk. So both of them is at risk, so that's why we have to go for such procedures. So for example, fetal distress, if there are some signs of fetal distress, we are going to mark the cesarean section. Abnormal position of the baby, the placenta issues, or any complication with the labor, so we are going to do C-section. Let's see the indications for C-section. So fetal distress, breech position, transverse position, multiple pregnancies, placenta previa, previous C-section, failure to progress in the labor, maternal health condition, hypertension, diabetes, or infection. These are some main highlighting factors or indications for the cesarean section that we have to do for sure. So and most important here is the previous history of the cesarean section. So there are chances of the rupture of the last scar. The previous scar can rupture and at any time. So due to this risk factor, the previous history of cesarean section itself become a risk for the next cesarean section. Let's see some questions. So in the first patient is a woman, 35 weeks of pregnancy. She is 25-year-old. She is having bloody discharges, medical history of 2 artificial abortions in a period of 28 and 32 weeks. So she had the history of abortions. So there were noted the onset of hemorrhage, and ultrasonography showed placental presentations. So when the placental presentation is there, the placenta previa, so we already know that we have to somehow go for the surgical thing as a treatment. However, the uterus is nomotonous. The fetal position is transverse, the first position they say. Nomotonous, I have written here the normal tone of the uterus. Placenta previa, presentation means placenta previa. Previa means the placenta is abnormally covering the cervix. So this is why she is having bloody discharges. However, I will explain the placenta previa in the upcoming videos very well, or in the next portions. So fetal heart rate is okay, but for example, we got the point what we were looking for, placental presentation. So we are going to mark the cesarean section for this question. So perform the delivery through the cesarean section. Let's go to the next patient. Next patient is secundipara. So she is already a mother of 2 children. I have written in the corner. So she has the regular birth activity. 3 years ago she had a cesarean section. So she's having a history of cesarean section for the reason of acute intrauterine hypoxia. So due to paradonia, paradonia means pain in labor. So she complains of extended pain in the area of post-surgical scar. Fetal pulse is rhythmic 140, which is okay. Vaginal examination shows 5 cm cervical dilation. Fetal bladder is intact. Treatment of choice, cesarean section. Why cesarean section? Because she is having the pain in the area of post-surgical scar. So we are already suspecting that the previous scar is rupturing already right now, because she is already having a painful sensation over that previous scar, and also she has a history of cesarean section. So we are going to mark or solve this problem with the cesarean section or a new operation itself. So next patient is 30 weeks. So 30 weeks patient pregnant had an attack of eclampsia at home. Eclampsia I'll explain in the means she got the seizures. In the next portions I'll explain the eclampsia. So her arterial pressure is 150 over 100. Predicted fetal weight is 1500 gram, which is low, very low. Actually it is a preterm baby. There is a face and shin porosity. Urine protein is this much. Parturient canal is not ready for the delivery. An intensive complex therapy has been started. What is the correct tactics of the case management? So delivery through the cesarean section. Why? Because of the eclampsia. This is what we needed as a risk factor. So she is having seizures already, so she is having a complication. So here the fetus is 30 weeks and he is having a very low birth weight. But even in the cases of 30 weeks, we can deliver the baby as a preterm because we have advanced care nowadays. So let's move to the next patient. Next patient is having 37 weeks of pregnancy, which is a term pregnancy, weak fetal movements, which is an abnormality, fetal distress. So we got what we needed. When there is fetal distress, just mark the cesarean section and move on. However, uterine cervix is tilted backwards 2 cm long. External orifice allows inserting a fingertip. So the cervix is open. That's how it is allowing one finger to insert. Bifacial profile of the fetus equals 4 point. So just so you know, biophasic profile 4 is equal to the abnormal. This is abnormal profile, and fetal risk increases. So we have to go for urgent delivery. So next patient is 6 hours ago her water broke and a 30-year-old gravida 1 para O burst. So her period was her early labor was pathologic, lasted for 2 days. The term pregnancy is 39 weeks. 39 is enough for the delivery. No labor activity is observed. Fetal head is pressed above the pelvic inlet. Heartbeat is okay, clear and rhythmic. Uterine cervix is not dilated. So even after the her labor has lasted 2 days. So and it is painful for the patient as well. So why to waste any more time? The labor is already having 2 days of the time limit. So still there is no dilation of the uterus. So no dilation of the uterine cervix. So we have to perform the cesarean section because the patient is in the pain and she already suffered the prolonged labor. So better to do the surgical choice. Next patient is 30-year-old, stage 1 of the labor, fetus, cephalic presentation. Cephalic presentation simply means the fetal head is toward the vaginal opening and buttocks are toward the uterus, so which is considered normal. Bradycardia. Bradycardia is something which we don't want to see in the fetus. So cardiotocogram is something which is used to measure the fetal heartbeat. So it shows decrease of basal heart rate down to 90 per minute. So 90 is low. Fetal heart rate should be like 110 to 160 or 150, around that. I'm not sure about the data because all the time they keeps on updating. So next, monotonous 2 or less. Late decelerations. Late deceleration I have explained here. Late deceleration are a type of fetal heart decelerations observed on the cardiotocogram that occurred after the peak of a uterine contraction and returned to the baseline after the contraction has ended. So this is simply the result of impaired oxygenation of the fetus. And monotonous variability also I have written here. Monotonous variability less than 2 beats per minute indicates the reduced or absent variability. So this is something concerning. So the main thing to remember about the question is fetal distress. So no need to remember about all of those things. This is for better understanding. When we see that fetal heart rate is low, so just choose the cesarean section and move on. Diagnosis for this question is a fetal distress due to inadequate oxygenation, and treatment tactics will be urgent cesarean section before the fetus die. Next patient is 34-week, underwent the Dopplerography of the umbilical circulation, revealed a diastolic component. So diastolic component, let's see what it is. When the Doppler waveform shows the reversal diastolic flow, it simply means that the diastolic phase, the blood is moving from away from the fetus instead of towards the fetus. So this is something very abnormal, that before the baby die, we have to go for the cesarean section. You can read the whole question, but we got the main key point here: reversal diastolic flow. So next question, why this question is highlighted this much? Because we marked this question wrong again and again. So let's see how to solve it correctly. So 34-year-old multipara has regular labor activity, which is good. Pelvic size is 26, 29, 32, 22. 6 centimeter is the cervical dilation. Amniotic sac is unbroken. Fetal heart rate, breech position. Breech position is buttocks towards the vagina, which is abnormal, which is considered abnormal, with the buttocks pressed to the entrance into the lesser pelvics. The promontory cannot be reached. No externus. Heart rate is 140. Expected weight is 2800. Tactics. So why the delivery through the natural birth canal? This question seems to be incorrect for me, but I still have to I still tried to make the sense. So breech position is there in this question, but however the vaginal dilation is significant, so we can try for the natural delivery. If there is and we have to keep on monitoring all the time. If there is any chance of complication, so we have to stay ready for the cesarean section. But just so you remember, and do not mark this question incorrect, or do not mark C section for this question. I have highlighted this thing very well, that even if the breech presentation of the baby is there, we still got the 6 centimeter of the dilation, which is really significant. After some time there will be full dilation. There are chances of full dilation as well, even if the pelvic dimensions seems to be narrow, but still the dilation is too much. So we will go with the natural birth canal. This question is wrong. Please try to remember it. I have marked it wrong a lot of times, so I hope you will remember this question. Another question: the labor activity of a pregnant woman is weak. Water contains meconium. Fetal heart rate is 90, which is low. So go for the urgent cesarean section. So let's go next. Next is preeclampsia. So preeclampsia is a pregnancy-related condition which is characterized by the high BP and signs of damage to the other organ system. Most often it is by the liver or kidney, which is typically occurring in the after the 20th week of gestation. So let's see the symptoms of it. The main symptom to remember is high blood pressures. So protein in the urine can be there. Protein in the urine, swelling, edema of the face and hands, sudden weight gain, severe headache, visual disturbance, upper abdominal pain. So a lot of problem with the pregnant woman. So there are 3 stages which I have seen in the test center questions. So they are asking about 3 of them itself. So remember about the BP ranges. They are the BP ranges. As we know by the definition that preeclampsia is characterized by the high BP. So let's characterize it with the high BP. So mild preeclampsia, the BP will be somewhere around 140, and the moderate preeclampsia 160, severe preeclampsia 180. Let's see some questions. So this is the question. The BP says 140 and there are proteins in the urine, so this is enough to mark mild preeclampsia, that there is high BP and protein in the urine. So this is what we were supposed to see in the symptom. High BP plus protein in the urine is preeclampsia. So 140, as you know that 140 is mild preeclampsia. Next question, you can read the question by yourself. So in the next question, the BP is 160 and there are protein in urine, which is significant for glomerulonephritis as well, like the nephrotic syndrome. So you know by the category that 160 is moderate preeclampsia. I don't have a question for the severe eclampsia, but remember I see somewhere the question in the test center that when they give BP as 180, the systolic BP, so it means severe preeclampsia. So let's go next. Next is eclampsia. So eclampsia is a very similar profile with the preeclampsia. Just add the seizure into the preeclampsia, it will be eclampsia. So let's see the definition. Eclampsia is the severe life-threatening complication of the pregnancy, which is characterized by the onset of seizures and coma in the woman with preeclampsia. So a woman which is who is already having preeclampsia, so when she start to get seizures, so we term it as preeclampsia. However, preeclampsia is the condition involving high BP and protein in the urine, which we just saw. So let's see the risk factors. A risk factor will be preeclampsia. The main remember about only the main risk factor, which will be preeclampsia if a woman is having high BP and proteinuria already. So this is the risk factor that the complication can occur, which is eclampsia. You can see other risk factor as well. For the first time, if pregnancy is there, if the age is younger than 20 or older than 35, if there is chances of multiple pregnancy, twins or triples, if there is history of preeclampsia or eclampsia, chronic hypertension, kidney disease, diabetes or obesity. So if there are these conditions, the woman is prone to eclampsia. Let's see how the symptoms will be. Symptoms will be seizures, the most important symptom, which will be best to seen in the KROK questions. Seizures, severe headache because of the severe blood pressure. So if there is a severe BP like this much, so there will be severe headache. Visual disturbances, since the CNS problem is there, having seizures, abdominal pain, swelling, breathing difficulties, high BP. So let's go to the first patient. First patient is 25-year-old. So a 25-year-old pregnant woman, 34th week, headache, visual impairment, nausea, and objectively there is solid edemata. Arterial pressure is 170 by 130. Sudden appeared fibrillatory tremor of the face muscles, tonic and clonic convulsions. Breathing came to stop after 1.5 minute breathing. Recovered. There appeared some bloody sputum from her mouth. Urine protein is 3.5, which is significant for the nephrotic syndrome. So let's see the main keywords of the point. So arterial pressure is severely high. The patient has got tonic and tonic convulsions, tonic and clonic convulsions. So the patient has a high arterial pressure. So the patient has high proteinuria and the patient got seizures. So preeclampsia is high BP plus proteinuria, and when the patient is having seizures as well, we are going to mark the diagnosis as eclampsia. So why there is appeared some blood sputum from her mouth? So we know that her breathing came to a stop for some 1.5 minutes. So the lungs were trying to compromise. So in the course of compromisation, some blood got released. So after her breathing is finally recovered, so some bloody sputum came from her mouth. So it shows the severity or the compromisation of the respiratory system or other systems of the body, that how much they are compromising. And since the condition is so severe, the seizures and arterial pressure, everything is so severe, even the proteins in the urine are so high. So let's go to the next question. Next question says similar conditions. There is BP 160 over 130. In the highlighted part, there is tonic-clonic seizures. But in this question, there is proteinuria is not given. So do not misdiagnose it. So you have to assume proteinuria at this time. So there are seizures and there is BP is there. So you can read the question or read the whole question. So mark the diagnosis eclampsia when you see seizures in a pregnant woman with high BP. So next is asking about the pregnant woman has a high BP and having a tonic-clonic seizures. Even this question did not said anything about proteinuria. So get ready about this thing that in the KROK questions, not always the proteinuria will be given. So they are asking about what drug must be administered. So we all know about this thing that magnesium sulfate is the choice of treatment for eclampsia. Next is placental abruption. Placental abruption simply means the premature separation of the placenta from the uterine wall before the pregnancy. So this can be caused by hypertension, trauma, any kind of trauma can cause this. Smoking, maternal smoking or cocaine history, cocaine abusing can cause this. Previous placental abruption, during the time of previous delivery, if there is any abruption has occurred. So a rapid rupture, polyhydramnios, advanced maternal age can also be marked as prone to placental abruption. So let's see the question, you will understand it. So the symptoms, first of all, symptoms are important. This symptom is exactly important, the sudden severe painful. There will be a sudden appearance of the pain and painful vaginal bleeding. This is what we are going to see in the KROK questions as well, that the abruption occurs very suddenly. So there will be severe abdominal pain, woody hard uterus. Why woody hard uterus? This is because when the placenta gets separated from the uterine wall, so that time it will lead to severe bleeding. So severe bleeding will all the blood will get filled in the uterine cavity. So the uterine cavity will be filled with the blood, all of it will seems to be very tight, and it will be looking like woody hard uterus, or on the palpation it will be like woody hard. Signs of fetal distress, since the premature separation of placenta has occurred, so the fetal distress we will see in the question, because there will be no more blood supply for the fetus. So let's see some question. The first patient is 27-year-old having 39 weeks of the pregnancy, bleeding from the genital tract plus abdominal pain. The uterine tone is increased, painful in the area of fundus. So the uterus is painful in the area of fundus. Ultrasound findings, let's see the ultrasound finding. The placenta is located near the uterine fundus. It means the position of the placenta is normal. So placenta is supposed to present near the uterine fundus, right? So this is the normal position. And next says is retroplacental hematoma. So this retroplacental hematoma suggests that there is some collection of the blood somewhere. So why hematoma? Because since we can confuse it with the placenta previa, so first of all, no need to confuse it with the placenta previa, because the previa simply means that the placenta will be abnormally placed over the or covering the cervix. So here the ultrasound shows the placenta is located near the uterine fundus. So if the placenta is located near the uterine fundus, this is normal, and still there is a hematoma. So why the hematoma has occurred? It's because the placenta has got abnormally or prematurely separated from the uterine wall. So there is only one cause of bleeding from the genital tract in this question, which is placental abruption. It means the placenta got ruptured or prematurely detached. This result in the severe bleeding, and that's why we have this retroplacental hematoma. It also means that on palpation we will see this woody hard uterus as well. This is the same because the blood got collected over there. So let's see the next patient. Next patient is 38 week. Same, the bloody discharge, sharp pain in the entire abdomen. We have seen in the symptoms that there is a sharp severe abdominal pain. So the same thing they are highlighting right now. No labor activity is detected objectively. The patient is pale, the pulse is 100, the BP is low, no fetal heartbeat. So no fetal heartbeat, it means there is no supply to the fetus. So no supply to the fetus means the placenta got prematurely separated. So mark the placental abruption. This is simple. So let's go next to the placenta previa. So placenta previa, I have just told you that this is abnormally positioned placenta in the lower part of the uterus, which will cover the cervical OS. So when it will cover the cervical opening, the symptoms which we will see is painless vaginal bleeding. So vaginal bleeding will be severe. By the way, I have made some point here that where the placenta is supposed to get placed. So this star mark is the internal cervical OS. So somewhere around this area, there can be a lot of type of placenta previa. It can be partially placenta can be partially covering the cervical OS, maybe fully covering, maybe somehow this and this covering, like this. There can be a lot of types, but no need to know about all of these types. So we will see painless vaginal bleeding. We will see bright red colored blood, because this time the pathology is near the cervix, not near the uterus. So bright red blood we will see. No uterine tenderness or no contractions. Preterm labor plus fetal distress because blood is getting lost from the due to the covering of the placenta, covering of the cervix with the placenta, or abnormal position of the placenta. So let's see some question. The question says, this is a 25-year-old woman hospitalized with the 34-week of pregnancy. So with the bright colored bloody discharge. So we see we already saw the bright colored bloody discharge, plus clots after defecation. Fetal head is palpable near the uterine fundus, which is highlighting the bridge position. The fetal head is palpable near the uterine fundus. So head is supposed to be near the vaginal opening. So next the question says fetal heart is 140, which is okay. No labor activity, which is not okay. Cervical opening is 3, which is low. Allow inserting one fingertip. So this line is the main for this question, which we need to remember. A soft formation can be palpated through the vaginal fornix. So near the vaginal fornix or near the vaginal opening, what soft formation can be there? The question is screaming about placenta is there. So the soft formation, placenta is that soft formation which can be palpated through the vaginal fornix. So back to the definition part. Placenta is abnormally positioned in the lower part of the uterus, covering the cervical OS. This is simply placenta previa, and the question just screamed about it, that a formation can be palpated through the vaginal fornix. So discharge will be hemorrhagic, bright red for sure. So we will mark the placenta previa. So next is a question about molar pregnancy. So in my first video, when I was showing the photos, so in that video I have shown the photo of molar pregnancy. So these are the vesicles I was talking about in that video. So let's read the question. 29-year-old woman having profuse bloody discharge from the genital tract, 3 months delay in the menstruation, having history of 1 childbirth and 1 abortion. So vaginal examination shows the significant amount of hemorrhagic discharge with vesicles from the cervix. So these vesicles are also known as moles from the cervix. So uterus is the body of the uterus is enlarged to the 15 to 16 weeks of pregnancy. And gonadotropin, this is also a hallmark finding in the molar pregnancy, that gonadotropin is also elevated in the molar pregnancy. So the main thing I have told in that first video also, vesicles. So here are those vesicles. So mark the molar pregnancy. One more question over the molar pregnancy, that this is 29-year-old patient profuse bloody discharge from the genital tract, 3-month delay of the menstruation, having history of 1 birth and 1 abortion. The discharge is hemorrhagic with vesicles. So we got the vesicles in this question as well, plus the gonadotropin in the blood. If you want, you can read all the question, and so mark the answer as molar pregnancy. So let's go to the next patient. Next patient is 17-year-old girl having profuse bloody discharges from the genital tracts, cramping pain in the lower abdomen. Last menses were 10 weeks ago. BP is 100/60, pulse is 90. Vaginal examination shows the external OS of the uterine allows inserting 1 finger. So by this point, that last menses were 10 weeks ago, the examiner want to highlight that she is pregnant, even though she is 17-year-old, but the examiner want to highlight that she is pregnant. And if the uterine cervix allows inserting 1 fingertip, it means we are sure that the miscarriage had started. So profuse bloody discharges are there, so the mark incomplete miscarriage, because we are sure that miscarriage has happened for sure, because of the cervix allows inserting 1 fingertip and there are profuse bloody discharges, so mark incomplete miscarriage. Let's go next. Next is a 28-year-old woman complains about severe mental trauma. So heavy bleeding started 20th day of the menstrual cycle, continuous 2 weeks. External genitalia developed, cervix is cylindrical, clean, which is fine. Body of the uterus is normal size, normal with the size, painless, mobile, flat surface. Uterus is okay. Vaginal phonesis are deep, parametria is free, which is okay. Vaginal discharge is hemorrhagic plus profuse. I guess in the question there is no pathology, because the external genitalia is very well developed, which is okay. Cylindric cervix is okay. The body of the uterus is the uterus is okay. Vaginal phonesis are okay. The only problem here is vaginal discharge, which is hemorrhagic and profuse. So it's dysfunctional uterine bleeding. This is only one case like this. So it's just the abnormal uterine bleeding without any another pathologies. So mark the option dysfunctional. So let's go to the next patient. Next patient is 38-year-old having tensive pain in the lower abdomen in the small of his back. Last month intensifies a day before menstruation. So premenstrual discharge is dark bloody. The history of 4 abortion plus 1 birth. So she is having a lot of abortions. Ultrasound shows increased foci of increased echogenicity in the myometrium, plus increased anterior-posterior size of the uterus, plus round hypoechogenic inclusions 2 centimeters. So if we go to the definition of the adenomyosis, I have told in the first video, in the animated videos. So adenomyositis, we can remember it like this, that adeno dives deep. So why the adeno dives deep? Because in the adenomyositis, the endometrial cells which were supposed to grow on the inner line of the uterus, they will go deeper into the muscle layer of the uterus. So the endometrial cells will invade the myometrium. This is known as adenomyositis. So you can remember easily through adeno dives deep. So let's see the ultrasound finding again now. So the ultrasound shows the foci of increased echogenicity in the myometrium. So there is something abnormal which is increased in the myometrium. So those endometrial cells has penetrated the myometrium this time. They are grown inside the myometrium instead of the endometrium this time. So increased anterior posterior size of the uterus, round hypoechogenic inclusions 2 centimeters. So what are those echogenic inclusions? They are simply the endometrial cells which were supposed to grow on the inner line of the uterus are now growing inside the muscular layer or the myometrium. So I hope this is clear. Let's go to the next patient. So the next patient is a 25-year-old, 2-month-long history of menstrual delay, vaginal bleeding discharge. Examination shows the cervix is the barrel-shaped. Uterus is the body of the uterus is small and painless. The external OS allows inserting a fingertip. Appendages are not palpable. Discharge is profuse and hemorrhagic. So they said something after the uterus, amphantaflexio. So this is I don't know the meaning of this, but in the KROK question they say a lot of things after writing EMPH. So I don't understand this, but we have got another things to mark about the question. So let's say barrel shaped uterus is seen in the ectopic pregnancy. So ectopic pregnancy is something which is the pregnancy outside the area of the uterus, like in the fallopian tube or somewhere. So the cervix is barrel shaped. This is the hallmark finding for the ectopic pregnancy. So the discharge is profuse and hemorrhagic, which is the result of abnormal implantation. Abnormal implantation means the zygote or the fetus or whatever has instead of implanting on the lane of the uterus, has implanted somewhere outside the uterine cavity. So it is the case of cervical pregnancy. So let's go to the next patient. Labor activity disorder. Labor activity disorders are the complication or conditions that arise during the pregnancy and the childbirth. So let's go to the next patient. 25-year-old multipara, first period of the labor, moderately strong contractions. Third pregnancy, history of cesarean section due to the clinically narrow pelvis. One artificial abortion, suddenly developed abdominal pain, weakness, blood pressure is severely low, moderate bloody discharges from the vagina. Fetal heartbeat cannot be auscultated. Labor activities ceased. So what the question is trying to highlight is moderate bloody discharges which occur suddenly. So when there is suddenly the pain start to occur, she has a history of cesarean section as well. So the labor activities ceased. Labor activities ceased because the uterine got ruptured. So there are bloody discharges. Suddenly it will develop because there is a previous cesarean scar is there. So when the previous cesarean scar is there, so if the bloody discharges occur and labor activity gets ceased, so mark the uterine rupture. Let's go next. So next patient is 37-year-old primigravida. Labor lasts for 10 hours already. Contraction lasts 20 to 25 seconds. Occurs in every 6 to 7 minutes. Fetal is in longitudinal lie with the cephalic presentations. The head is pressed against the entrance to the lesser pelvis. Uterine cervix is 1 centimeter long. Allows 2 fingers only. Amniotic sac is absent. What should be the diagnosis? So in the question, we see that the labor lasted for 10 hours and the dilation shows only 1 centimeter. So in 10 hours, if the dilation is just 1 centimeter, so it means the labor activity is weak. It is simply means the labor activity is weak. So when the contraction is occurring first of all, the contraction lasts for 20 to 25 seconds. The contraction should last up to 55 seconds to 1 minute. So that should be the range of the contraction which is best for the delivery. And the contraction occur in 6 to 7 minutes. The contraction could occur in more frequently. If the case is normal, then we will see that contraction will occur more frequently. But to mark the answer of the question, primary weakness of the labor activity, we got the point that the labor activity has lasted for 10 hours already, and still the cervical opening is just 1 centimeter. So it is the primary weakness of the labor activity. Next patient is 38 weeks, small amount of bloody discharge from the genital tract and sharp pain. Sharp pain in the entire abdomen, started 1 hour ago. No labor activity can be detected. Patient is pale, pulse is 100 and blood pressure is 100/60. No fetal heartbeat. So we remember from the symptoms of placental abruption that sharp abdominal pain occurs in the cases of placental abruption when the placenta gets gets prematurely detached in the cases of abruption. So no labor activity because the placenta got detached. No fetal heartbeat is detected because the placenta got detached and there is no more supply of the blood to the fetus. So we got our point. No fetal heartbeat with the sharp pain in entire abdomen. So let's go next. Next is another case of primary weakness of the labor activity. So in this case, the contraction lasts for 20 to 25 seconds. Remember the last time the contractions were also lasting for 20 to 25 seconds. As I have told you that the contraction can last up to 55 seconds easily. So that will be considered as a good contraction. If the contraction lasts up to 55 seconds or 1 minute, it will be the good or best contraction. But in such cases now the contraction is lasting from 20 to 25 seconds. The occurrence of the contraction is better in this case 4 to 5 minutes. So water broke 2.5 hours ago. Fetal heartbeat is 136. Small segment of the fetal head lies in the plane of the inlet into the lesser pelvis. Cervix is smoothed out. Opening is 4 centimeter. So the contraction occurs in 20 to 25 seconds. This is the weak point, and the opening is still 4 centimeter, which is still very low for the delivery. Amniotic sac is absent. Which complication would have occurred? So this is we can understand that the problem is with the opening, the vaginal opening or the cervix opening. So if the problem is with the cervix opening, the baby could not be delivered. So that's it means the primary weakness of the labor activity. So the labor is weak, that's why we mark the primary weakness of the labor activity. Let's go to the next patient. After birth of twins, the post-parturiate movement developed massive hemorrhages from the natural birth canal. Placenta and birth canal are intact. Uterine fundus is located above the navel. The uterus is soft on palpation and doesn't respond to the administer of urotonics. Cause of the bleeding. So in this question, urotonics are the medication for the uterine atony. I have written here. So the thing is, in this case, failure of uterus to contract after the birth. This is postpartum hemorrhage. So even after the delivery of the birth of the twins, the uterine fundus is located above the navel. It should be around the navel by this time to keep the phenomena alive for the physiologic involution. So at this case, the uterine fundus is located still above the navel. So it is not getting back to the normal size, or the physiologic involution is missing here. So it basically means that the tone of the uterus is low. So this is the case of uterine atony. So uterus is soft on palpation and doesn't respond to the administer of urotonics. So even if the doctor has provided her the medications, the urotonics, so that her physiologic involution can occur, or the uterine fundus can get back to its normal size, or get back to the place or in the pelvic cavity. So even after the administration of urotonics, the problem still persists, which is uterine atony. Next question is a pregnant woman, a 25-year-old woman, has pain in the right iliac region, has lasted already for 10 to 12 days and a menstrual delay of 7 to 8 weeks. Palpation detects the pain in the right iliac region, pain in the right vaginal fornix, but no enlargement of the uterus or ovaries. A right-sided ectopic pregnancy is suspected. Examination method. So the patients, the examiner simply want to know about if we know that what is the choice of diagnostic method for any kind of pregnancy, or let's say ectopic pregnancy. So we always go with the ultrasound procedure, because ultrasound is the most basic non-invasive procedure, and moreover it is safe for use, and it is faster method. So we'll go with the ultrasound. Next is abortions. So we all know what is abortions. So there is only one question in the KROK which I have seen over this thing. There is 31-year-old woman who came to the gynecologist who is having menstruation delay of 2 weeks, morning sickness, smearing bloody discharges from the vagina. Pregnancy test is positive. Ultrasound detects no fertile egg in the uterine cavity. Patient must be referred to the following study. Ultrasound findings says that there is no fertile egg in the uterine cavity. So if the pregnancy test is positive, and if the fertile egg is not in the uterine cavity, so where it is? It can be in the fallopian tube. It can be the case of ectopic pregnancy. So what we are going to do is we are going to do dynamics of HCG level in the blood. Please do not misdiagnose it. In the option, HCG level in the blood will also be given, so don't mark HCG level in the blood, mark the dynamics of the HCG level in the blood, because the HCG levels doubles in the pregnancy in every 48 to 72 hours. So we are going to mark the dynamics of HCG in the blood. Next is ovarian apoplexy. Ovarian apoplexy simply means that ovarian rupture or ovarian hemorrhage. So the sudden rupture of the ovarian follicle or blood vessel or cyst can lead to bleeding within the ovary or into the abdominal cavity. So since it is ovarian rupture, so ovarian rupture, as you can imagine, that when the ovary will be getting ruptured, so the pain will be very sudden, sharp in the lower abdominal area, or let's say in the pelvic area. Nausea, vomiting, dizziness, lightheadedness, fainting due to the blood loss. If the blood loss is severe, the patient can meet syncope. Abdominal distension or bloating, pain during the physical activity or sexual intercourse. Low BP is also a hallmark finding for the ovarian apoplexy. I mean, it will help you to diagnose or mark more for the apoplexy. Or high heart rate. Some main symptoms are here, I guess. Sharp lower abdominal pain, dizziness, negative HCG result, and low BP. They are symptoms which are important to remember, that sharp pain will be there, the lower abdomen, dizziness, and negative HCG result. There will be no pregnancy reports, so low BP will be there. Let's see the questions. The question says that sharp pain in the lower abdomen. The question itself screamed that sharp pain is there in the lower abdomen, and short-term loss of consciousness. We can already assume that it could be due to the blood loss. Yeah. So at home, last menstruation was 12 days ago. Uterus shape is normal, painless. Appendages on the left are slightly enlarged and painful on palpation. The one of the main thing which the KROK question says or doesn't forget to say, posterior fornix overhangs. So never mark the ovarian apoplexy as an answer until you see the posterior fornix overhangs. But if you see posterior fornix overhangs in some another questions, so doesn't mean that you will mark the answer ovarian apoplexy. I'm saying is that if you are marking the answer ovarian apoplexy, so just do not mark it until you see the posterior fornix is overhanging. So basically in the questions it is given, even in the next question, the posterior fornix is overhanging. So we see the profile of apoplexy right now. Sharp pain in the lower abdomen, the loss of consciousness due to blood loss, posterior fornix overhangs. So this is the apoplexy of the right ovary. So another patient is 27-year-old, states that sharp pain in the lower abdomen again. So HCG test is negative because there is no pregnancy case. Last menstruation was 2 weeks ago. Skin is pale. BP is severely low. BP is severely low. Why? You know that there would be blood loss for sure. That's why the BP is severely low. Pulse is 92. Abdomen is tense, painful, more on the right. Painful, more on the right in the lower segment, because probably the right ovary would have ruptured. The vaginal examination shows the normal sized uterus. The uterus is okay. Appendages are painful or on palpation. So appendages are what? Fallopian tubes and ovaries. These are the appendages of the uterus, right? So appendages are painful because the ovarian apoplexy. So something would have rupture, like the sudden rupture of ovarian follicle, or blood vessel, a cyst, or bleeding within the ovary or into the abdominal cavity, anything or something, some pathology, or some pathology would have occurred, due to which these findings are there. So, and again the question says the posterior fornix overhangs, so we can go for the ovarian apoplexy. So this is it with this video. The video is getting longer, so I'm going to make a part 2 for it. So stay tuned for the content. See you in the next video.